Good afternoon, everyone, and welcome to the Board of Pharmacy webinar today. I'm Tom Glinsky, Chief Inspector with the board, and today is our annual compliance update with an extended question and answer session. Let's see. With me today, I have a couple inspectors. I have Elena Wolzak, who is the inspector in the Kansas City area and area south of Kansas City. And then I have Katie Diebold also here with me. She's our sterile compounding inspector that handles mainly St. Louis area, but you can also we'll see her around the state at sterile compounders. If you haven't been on one of our webinars before, you all are muted in listen only mode. If you have any trouble with your computer audio, you may go to your toolbar and choose the phone call option and then use the access code to gain access to the audio. This has been approved for 1 hour of CE. You cannot share computers or share logins. You must be logged in to go to webinar under your own username in order to receive credit. You do not receive credit if you're only listening via the telephone and not logged in. At the end of the webinar today, I will go over further instructions for CE. Just a reminder, we do not submit to the CPE monitor, so save your certificates. And do not assume another state board of pharmacy will accept this. You want to double check with them that they will take CE that's been approved by another board. Handouts are available on 2 spots. We did change on the board's website where they're at now. We were going forward. They'll be there permanently. If you go to the upcoming events thing, there's a link there, or if you go to the video webinar sections, you'll see a link there that will take you to all the webinar handouts from this year are posted there, and they will remain posted after the webinars going forward. And then also on your GoToWebinar toolbar down at the bottom, you'll see a tab. It says handouts. There'll be a PDF there of the handouts. We do record our webinars and post them on our website. It can take up to 15 days before they show up there, but all the previous ones from this year and previous years are on our website. We do have the extended question and answer session today. If you'd like to submit a question to us during the webinar, go to your toolbar, go to the tab that says questions. You can type it in and hit send. We also ask that people send them in advance. We do have a few of those that we'll go through. We're going to do those first today. So we'll get started today with the webinar. I'm going to talk about immunization since we had some major changes through the legislative session that took effect in August. I want to do a refresher on that, and then I'll just go over some of the common pharmacy inspection observations. Because we have a couple inspectors here with me today, we'll have some conversations with them on some things they see and they do. And then, as I mentioned, we'll have that extended question and answer session. So we'll move on to immunizations. As I said, there were major changes this legislative session to the statute. That statute change became effective August 28th. In response to that statute, the board had to change the immunization by protocol rule. That's 6.050. And so right now there's emergency rule in place. You can click the hyperlink to take you there that revised the previous rule to match the current statute changes. And then the emergency rule was also published as a final rule for comment. That was in the Missouri Register on 9/15, so it's currently in its 30-day comment period. If you'd like to submit a comment about that rule, you can. There's instructions in the Missouri Register on how to do that. The comment period ends October 15th. And just to let you know, the name of the rule is being changed. We're dropping per protocol from the name of that rule. So 338.010 is the Practice of Pharmacy Act. It defines what the practice of pharmacy is. The statute not only added this about immunizations, but it also cleaned up the way it was written. Instead of being one long paragraph, it's now into multiple sections now that makes it easier to read. And Section 4 gives pharmacists the independent authority to order and administer certain vaccines. So you have independent authority now, the pharmacist does. No protocol is required going forward. You'll be able to do it on your own. The patient age requirement stayed the same. It's still 7 years of age, or what's recommended by CDC if it's older than 7. So 338.010 now says you can order and administer any vaccine approved or authorized by the FDA on or before January 1 of 2023, with the exception of these 14 vaccines listed here on the slide. These 14 are excluded. You do not have authority to independently order those, and you cannot use a protocol to administer those either. But here's some of the vaccines that now you can do that previously you weren't able to do. You can now administer these, order and administer these independently. You'll see the list here. These are the ones that were approved prior to January 1 of 2023. So lots of questions about the statute change on what about future vaccines? Well, the authority that was given to pharmacists in the statute change does not include any vaccines that are approved after January 1 of this year. So we get lots of questions about RSV. RSV was approved after that, so it is not, pharmacists are not allowed to order or administer that based off independent authority. It will require a legislative statute change in order to get RSV added to the statute in order for you to do it by that method. Other questions we get is about what about reformulated or updated vaccines? Example is the yearly influenza reformulation. Can we continue to do that? The emergency rule does address this, and it says that pharmacists may administer reformulated or updated vaccines, even though they were reauthorized after January 1 of this year, provided that the initial vaccine was approved prior to January 1. So the flu vaccine's been around for a long time, so the yearly updates to that do not fall into that exception that you can't give it. So we will, as other ones, if there's revisions to any of the other ones that you can currently do, it would fall under this too. We do get some questions about any future combination vaccines, such as a COVID/combo with flu. We don't have an answer yet to that. Once that, if it does get approved, the board will have to issue some guidance on how that falls under this. The statute change does now require some patient screening. The emergency rule includes 2 new requirements, even though pharmacists have already been doing these, doing a patient screening. So patients need to be screened prior to ordering the immunization, and you must document that screening. Like I said, that's currently being done. On inspections, we see, the intake form where people are being screened and pharmacists are reviewing that. So I don't see a lot of major change there. And there's also a requirement that you refer patients who have a contraindication to a vaccine to their primary care provider or other appropriate healthcare provider as deemed necessary. So those are in the rule. I don't believe there are anything new that pharmacists aren't currently doing. There are some new documentation requirements in the emergency rule. related to vaccines ordered by a pharmacist, and it has a list of 6 things. 5 of them are already probably in your vaccine administration record. It's very similar to what you're already keeping, but the 4th one there, the identity of the ordering pharmacist, should that be different than the one of who's administering it, the pharmacist administering it, then that would be a new requirement. This new documentation requirement can be the same information as your vaccine administration record. It can be the same document. You don't need 2 documents basically saying the same thing. They could be combined into one. And then the rule also says the vaccine administration record must now document patient screening, which from what I see, your records already do that. So I don't see any major change there. So prescriptions that are generated from the pharmacist's independent authority to order vaccines, the pharmacist will be the prescriber on any prescription for that. So make sure your system is set up. Don't be using any protocol physicians as the prescriber if the pharmacist is the one actually doing the ordering of the vaccine. So the immunization protocol that you previously used are still allowed. The emergency rule does address that and say you can continue to use that if you choose. It's not required, but some pharmacies choose to do that. I believe it's probably due to billing, easier billing if they're using a protocol physician versus a pharmacist. But again, it's optional, it's not required. If you are going to use a protocol, the previous requirements still apply, but now they can include any vaccine that a pharmacist may independently order and administer cannot be done by protocol. So in the past, COVID-19, after the emergency waiver went away, you couldn't add to have that on a protocol. That COVID-19 now can be part of a immunization protocol. What you cannot include is RSV, since pharmacists can't independently order that, it cannot be given under an immunization protocol either. So just keep that in mind. We've had a lot of questions about RSV and can it be added to a protocol. The rule was revised to match the screening requirement. Now says that your protocol must address patient screening requirements. I don't think that's anything new. Most protocols in the past did address that. And then just a reminder that when you're using a protocol, the protocol physician is a prescriber on any prescription for a vaccine given by protocol. We have had a lot of questions about notification of intent or NOI. If you currently have an NOI to administer vaccines by protocol, you do not need to issue a new one if you're going to be doing it by independent authority. You will be able to renew that. All NOIs are renewed at the time you do your pharmacist renewal. It will look a little different. The name will change, but at the time you do the renewal, but you don't need to do a new one if you currently have one. And then, like, we do get asked, do interns and the qualified technicians who are administering need to submit an NOI? And the answer is no, they do not. And just a reminder that there are 2 different NOIs. There's one for administration of vaccines, and that's either by your own authority or by an immunization protocol. And then there's a separate NOI if you're doing it by administration by medical prescription order. So on the website, when you go to the online services to submit one, you have to choose which one you're doing. And if you need to do both, you got to go back and restart the process and do it again for the second type. Speaking of administration by medical prescription order, you can use this method to do any vaccine that's not allowed under pharmacist independent ordering. So RSV could be done by administration by prescription order. You can obtain a prescription from a prescriber and then administer the RSV. This would also apply to any future FDA approved vaccines, and it also applies to the 14 vaccines I previously listed that are prohibited. So prescription order can always be used to do any vaccine. And then just a reminder, you can also administer under age 7 by prescription order if it's within CDC or manufacturer guidelines. So it does give you more leeway on age also. And then we get commonly asked about using mainly nurses to administer in the pharmacy. The pharmacist can only delegate their administration to an intern or qualified technician. However, the board a couple years ago issued guidance, and it's in the practice guide section M4. It's titled delegation. It's technically not delegation to other healthcare providers. It's actually the use of other healthcare providers. And if you read that in the practice guide, it'll tell you how you can use another healthcare provider, such as a nurse who has their own authority or independent authority to administer. They can use the pharmacy stock. The pharmacy, it explains how you can create a prescription in order to help billing for that. So if you have questions about that, I would refer you to the practice guide and read that section if you want to use a nurse to do any immunizations. Just a reminder, we have various documents on the website. We have the practice guide, and then in August, we issued a supplement to the practice guide to address all the statute changes. And in that is a section on the immunization changes. On August 17th, we held a legislative update webinar that talks about that. You can watch a recording of that on our website. And then recently, we updated the immunization administration checklist to match the legislative changes. And then we also created a new template of what a technician immunization assessment checklist would look like. So here's photos. That's the checklist immunization. It's actually double-sided. One side's for vaccines. The other side is for by medical prescription order. And then here's just a sample of one of the sections. I believe the assessment has, I think it's 36 questions that you would ask or watch when a technician is being assessed for their administration technique and stuff. And this is just a sample. We were asked, to create one to help pharmacists out. I know some pharmacies have their own. You're not required to use ours. It was just a sample to provide some guidance on what one might look like. I want to jump over now real quick to just common inspection observations. We do maintain a top 10 list on our website. We just updated it in July. This is what it looks like. You can't read it there. So here is the actual top 10. They're in no specific order, but when we poll the inspectors on what this is the top 10 that they give. You will see some new additions to the list over on the right side. Back in August last year, there was a rule change and some of the requirements are photos attached to all licenses, so technicians have to have their license there, and then the requirement for name badges. And so we do see some observations of people not following those. The other ones, again, I believe were on previous lists. Okay, so now that as I mentioned, we have a couple inspectors with it, we'll get in a conversation with them on just some of the things they do. So Elena and Katie, sometimes we get asked, what tips do you have for pharmacists in charge and pharmacies in general to have a smoother inspection?
Good afternoon, everyone. This is Elena Wolzak. I would have a couple of tips for a smooth inspection. One would include completing the pharmacy self-assessment that we have that can be found on our website. A PIC who completes this, it can receive 2 hours of CE each calendar year. And you can use this self-assessment tool as often as you would like, but we would recommend that it would be a good tool for you to use to check your pharmacy compliance at least once in between your inspections. Also, we do have a document called our records locator. We do hand that out on inspections in the folder that you receive. It's also on our website. It's a real good document to use to notate where items are found in your pharmacy. And those are the items that we are going to ask you for on inspection. And along with that, if the person who knows where the items are located in your pharmacy or knows how to access electronic items in the computer, such as the pseudoephedrine database, if you're storing your temperature records electronically, if that person is not present for the inspection, it is a really good idea to make sure you do have some kind of backup contingency of someone else in the pharmacy who would know how to access those items and where to find those items.
Okay, thanks, Elena. Katie, from a sterile compounding perspective, do you have any tips?
I sure do. So hi everyone, this is Katie. So for a smooth sterile inspection, of course, you can utilize many of the resources that have already been discussed. We don't currently have a sterile self-assessment form, but you can use, on our website, there's a blank sterile inspection checklist, and you can use that as sort of a self-inspection that you can do ahead of time. And then I also recommend reviewing previous inspection reports that you've received, especially true if you're newer to the pharmacy. You can kind of review what are some previous compliance issues that the pharmacy has experienced, and then you can make sure those are fixed, prior to the inspector coming in. And then also just in general, know what to expect. So for the sterile portion of the inspection, you can expect a document review portion and then also an observation portion. So for the document review part, you can again utilize that inspection document request form that Elena mentioned. There is a section specific to sterile compounding on there, so you can go through and make sure you have all those documents ahead of time. If the documents are paper, I recommend having a centralized location for those, so a binder, a filing cabinet, something like that. If they're electronic, as Elena mentioned, know how to get into those, know your username, your password, know how to operate those. A lot of people, especially with the sterile compliance software programs, they'll know how to show me how to document something in real time. Like for cleaning, they'll say, oh, this is how we document cleaning. But then it's hard for them to go back in time and show me what's been completed. So make sure you know how to utilize your software to be able to show what's been completed. And then also compound logs, a lot of them are becoming electronic. Make sure you can, again, access those reports kind of after the fact, after the compound's been completed. Especially true if you're using the systems that take pictures of the compounds. Those can be kind of tricky to navigate. And then for the observation portion, I just know what to expect. Tell your employees that the inspector will be inspecting the compounding area. They'll be observing personnel and then also cleaning. And if there's no compounding going on that day, at a minimum, we will request hand hygiene to be demonstrated as well as cleaning. So just so people aren't kind of taken off guard when we ask about that. And then ideally, if you have, we'll want to observe the person that normally does the compounding. So if you only have one person trained, as Elena mentioned, it's a good idea to cross-train so that others can assist or answer questions. So those are some good tips to help for a smooth sterile inspection.
Okay, thanks, Katie. Elena, what violations do you see most during an inspection?
I would say the most common violations I've been seeing are unsanitary conditions, such as excessive dust buildup on the shelves, pharmacy floors not being cleaned, loose pills being found on the pharmacy floor, sometimes on the shelves. The fill master or your reconstitute that you're using is dirty or has a lot of splatter on the underside and it needs to be cleaned. Also seeing dispensing errors on inspections, outdated drugs. With the new requirement with the name badge, I've seen quite a few staff that aren't wearing their name badge, and also seeing patient counseling not being offered on all prescriptions.
Back on unsanitary conditions, I will tell you, I've just noticed in the last year we've had a lot of leaky pharmacy roofs.
Yes.
For some reason, I don't know what, but I've seen more observations about leaky roofs. So if your roof's leaking, you need to get it fixed. Katie, how about on the sterile side?
Yeah, for sterile, I think number one is kind of goes back to the unsanitary, maintenance of your compounding area. maintaining it and cleaning it appropriately. So some of the common things we see are areas of rust, chipped paint, exposed drywall or laminate, cracks. All of those, can create particles within your environment, which can then spread contamination to your compounds, excess residue or buildup, excess dust or debris, and then a lot of spills that just never get cleaned up and they just kind of hang out. So all of those can pose microbial and non-microbial risks to the compound. So definitely recommend doing more frequent audits of your compounding area. Don't just rely on your staff to tell you that there's a problem. Actually go in there yourself and check it out on a routine basis. And then also just training, general training with media fills, aseptic technique skill assessments, whether they're late, incomplete documentation, missing certain observations. That always tends to be an area where people can improve. And then aseptic technique violations, so just your employees being, kind of goes hand in hand with the training, right? Making sure that they're doing everything correctly. Don't just rely on the annual and initial training. Make sure you're doing audits that they are still keeping up with their proper technique. That way, when we come in, everything looks good.
Okay. Let's switch to investigations now. What are some common investigations that you both conduct, and how do you conduct them?
Probably two of the most common investigations I have to do with errors, dispensing errors at the pharmacy, and also customer complaints about understaffed pharmacies. So I'll talk a little bit about how we investigate errors. We first want to identify what type of error has occurred. Is this an input error, filling, selling error, a robotics involved with this error, any kind of remote entry involved with the error, and what processes were involved, and the staff who would have been involved in any of the processes associated with the error. And then, is the pharmacist in charge aware that an error has occurred? And then I would like to ask the PIC if there's a root cause analysis that has been conducted by anyone in the staff, and what action they may be taking to determine what may have led and caused to the error, and if there was any corrective action that would be needed. And along with that, there would be some data that we would want as part of the investigation. We would want to know the pharmacy workload and staffing, and the pharmacist activity data, such as the number of prescriptions dispensed, number of vaccinations provided, any type of testing being performed, and pharmacist and technician hours on the day of the incident. We would also like to know the number of prescriptions that the pharmacist verified and the number of hours that the pharmacist worked on the day of the incident. Also, as part of dispensing error investigation, your inspector will conduct a review of several other prescriptions at the pharmacy to see if any additional errors are found. If additional errors are found, then you would be issued, the PIC would be issued one of our quality assurance reports. And this is a document that the PIC would need to fill out and respond to the board. And it asks questions for the PIC to respond to, such as if the error reached the patient, if the prescriber has been notified, possible causes and contributing factors to the dispensing error, corrective action taken, and again, total hours worked by the responsible pharmacist the day of the incident. We also want to ask and make sure that if the PIC is aware of the error, is the responsible pharmacist also aware of the error, and is there any type of education associated with going over that with your staff, and do you have meetings to help prevent future errors? The other investigations that I have been conducting have to do with customer complaints that the board receives about understaffed pharmacies. And for investigations related to these types of complaints, the inspector will be asking the pharmacy about their staffing policy. We'll be visiting the pharmacy, looking to see if there's a backlog of prescriptions, asking if any pharmacy services have been decreased. How long has the issue been going on? Who sets your schedules? And are you getting any type of external help? Have you received any type of additional support? Is there a plan to reduce pharmacy demand? What's actually being scheduled versus the actual staff present? The inspector will also look for unsanitary conditions, outdated drugs. Again, the inspector will be reviewing several prescriptions. Inspector will also want to observe how long your customer lines are while we're at the pharmacy. Are the phones being answered by pharmacy staff? What has been done to remedy the situation by the pharmacy? Has management, any type of upper management or leadership communicated with you? Have you communicated with them? Have you any type of plan for additional support, or is there a plan to reduce your pharmacy demand? Again, we would be also asking for your pharmacy workload, staffing, and pharmacy activity data for the specified time frame that we may be looking at.
Okay. Katie, how about on your side?
Yeah, so in addition to those, kind of already mentioned, I will do a variety of investigations, but I do especially a lot of compounding violations. And many of those involve non-resident pharmacies, so those that are located out of state and shipping into Missouri. So those investigations can include allegations such as compounding commercially available products, recalls, violations related to risk level 3 compounding. So that's our non-sterile to sterile compounding, multiple sterile compounding violations that are found by other agencies, or maybe something like office stock compounding, since that is not allowed in Missouri. So the way that I start those investigations is I'll just request a list of all the preparations shipped into Missouri. I usually pick some kind of time frame and ask for those records. I'll ask for prescription records and then also distribution records to see kind of what the pharmacy's doing. I'll review those lists and then select some to review. So I'll ask the pharmacy to then provide more data related to the ones I've selected, such as prescription records, compounding records, and then any end preparation testing that has been done for the compounds, and I will evaluate compliance with our rules. Since Missouri's rules are stricter than 797 in some areas, I will review specifically with the risk level 3 testing to make sure that they're compliant with those. If there are commercially available preparations on the list, then I'll request prescription records to assess the reason for compounding, if they've documented a medical reason appropriately. And all of this could apply to non-sterile compounds as well. It's not just sterile. And then if there's recalls involved, I'll ask about the details, what was the cause of the recall? And then I'll also want to know corrective and preventative action that the pharmacy has taken for those types of scenarios.
Okay, thanks, Katie. Let's see, before we move on to our question and answer session, what are some common questions you two have been receiving lately?
A very common question I've been receiving lately is, can I administer the RSV vaccine via protocol? I've received a lot of questions. And Tom's already discussed this, and that at this time may only be administered via prescription. Another common question that I've been receiving has to do with the new allowance to transfer an initial controlled substance prescription. The DEA has recently issued a rule which allows for the transfer of an electronic prescription. And this only applies to electronic prescriptions. This wouldn't apply to a verbal prescription, a written prescription, or a faxed prescription. But Since this is a DEA rule, you would want to review DEA for what is required to perform this initial transfer. Again, the rule for DEA is 21 CFR 1306.08. And if you have any questions, again, contact DEA for guidance. Tom will be discussing in this upcoming slide where you will be able to be given information on email addresses for DEA and BNDD. We do receive a lot of questions about controlled substances, and a lot of times we do have to refer you to Missouri BNDD and the DEA to answer those questions.
Katie, how about on your end?
Yeah, so the big one I've been getting a lot is USP chapters. What are we doing about them? Specifically 797 and 800. Sometimes people throw in 795. And for those not familiar, 797 is sterile compounding, 800 is compounding of hazardous drugs, and then 795 is non-sterile compounding. So the big question is, will the chapters be enforced by the board this upcoming November when they're slated to become official? And in order to enforce the new 797 revisions, the board would have to revise our rules, and they haven't done that yet. So the board does plan on having a discussion soon. I don't have a timeline yet of when that'll occur, but maybe some upcoming board meetings, and they will then decide what to do at that point. They kind of have some different options. One, they can adopt USP 797 in its entirety, or they can revise our rule and decide to incorporate pieces of the new USP 797 into ours, kind of pick and choose what they want to include in there. So if they decide to adopt USP 797 entirely, that would automatically make USP 800, 825, and 795 compendally applicable as well. So the board also has a decision that they need to make there about if they want to make those enforce those all the way across, so that they kind of have some decisions to make and they're able to decide, you know, what they want to do. For the time being, our current sterile compounding regulations 2.200 apply, and any reference in our rule to 797 is specific to the current version, so the 2008 version. And this will be true in November and until our rule is revised. So basically just continue complying with our rule, and we'll update you guys as the board decides. And as always, we can't really speak for what other agencies or accreditation organizations may require, so definitely look into that. You want me to do another one, or? Okay.
Okay, we'll move on to our question and answer session. We're going to start with the ones that were submitted in advance. And just so you know, we may not answer all questions that are given. There will be some questions we are unable to answer. We'll start with what came in prior to the webinar today. So our first one was, please provide status of the prescription monitoring program in Missouri.
The state PDMP is being managed by the Office of Administration. We were told the PDMP is on track to be fully operational by the statutory date of January 1, 2024. Right now, they do not have a go live date at this point. But they will be communicating with prescribers approximately 4 to 6 weeks prior to the actual go live date.
Yeah, and just to let you know, I am working with their executive director to have him come do a webinar with me on the PDMP. I don't have a date yet for that. We'll announce it via our e-alert system once we have a date for that. Let's see, under the new pharmacist authority to order vaccines, can a pharmacist delegate the administration to a nurse?
No, so delegation can only be given to an intern or a qualified technician. As Tom previously mentioned in the presentation, there is guidance in the practice guide on how a nurse may be used.
Okay. Let's see, for MTS agreements, does the patient need a new consult from the physician every year?
Under the current rule, yes. However, with the recent statute change, that will do away with the requirement. The rule will need to be revised to match the statute.
And then as Katie mentioned, we get lots of questions on USP chapters. We had multiple of those come in. We won't, Katie pretty much answered those already. So unless, I think we will skip those. For students who graduated in May, what are the CE requirements before the next renewal time?
The rule exempts CE requirement for those first license within the 12 months immediately preceding the October 31 biannual renewal date. So if you're already licensed, the 30-hour CE requirement will apply when you renew next year.
Okay. We have a question about perpetual inventories and how do you handle broken tablets on your inventory? And they're asking, can it be a separate log or does it have to be one log? How do you handle that?
So the board actually doesn't require a perpetual controlled substance inventory except for certain license classes, and those are N, O, and R. So for those classes, the broken tablets do need to be logged, but it's up to the pharmacy on how they choose to do that.
And just a reminder, if you want to submit a question to us during the webinar, you can go to your GoToWebinar toolbar, and down at the bottom, you'll see where you can submit a question. We have a question about out-of-state pharmacies compounding sterile injections and shipping them into the state for and to clinics who are then reselling the products. Examples of actually saying the drugs might be unlabeled, and we want to know what's the board doing about that.
As Katie's previously mentioned, the board does investigate out-of-state compounding pharmacies. We are aware of the issues that are being raised, but we really cannot discuss any kind of specific investigations.
Let's see, we have someone asking about using digital images for their faxes that they receive. Do they have to, if they have an electronic fax system, do they have to still print the fax? And then a second follow-up to that is, how do you handle the prescriptions generated for immunizations? Are you required to print those out?
So the board rules do allow for a digital image of a prescription instead of a physical hard copy prescription. If a pharmacy complies with the image rule, non-controlled faxes do not need to be printed. However, the DEA requires a hard copy for fax controlled substance prescriptions, so keep that in mind. And then for immunizations, you must have a hard copy or an image of a hard copy. And then there's some sections in the practice guide, K4 and 5, that have more information on that.
Let's see, when immunizing under a protocol, are we allowed to give Gardasil and COVID-19 vaccines, which we previously weren't allowed to?
Yes, that is correct. You could administer anything that you would be allowed to independently.
Let's see, is Missouri considering shift hour limits or required breaks for pharmacists, like 8 or 12-hour maximum with lunch or rest breaks?
So the board is aware of the pharmacy staffing and workload issues, but they have not proposed any required breaks or hour limits at this point. The board's 2021 statement on working conditions encourages permit holders to ensure staff have sufficient rest and lunch breaks throughout the day.
Next one's related to the new requirement to be monitoring temperature in the drug storage areas. Do you have to do a manual recording if you have an electronic system?
For drug storage areas, a continuous electronic reporting system that provides alerts when the temperature goes out of range can be used instead of manual recording.
We have a Question was asked about the CMS waivered hospital at home programs how do they function, and how do you treat the inpatient order? Do you treat them like inpatient orders, or do you have to follow board's requirements for prescriptions?
So the board hasn't issued any guidance on this topic until such time that they do. If the DHSS considers the patients enrolled in these programs to be patients of the hospital, then the DHSS rules would apply. But really, you need to contact DHSS for guidance on that.
And if the asker we have an email address that goes directly to the hospital section at Department of Health. So if you would email us, we could give you that if you wanted to ask for more guidance from them. Let's see. Can you provide a model for compliance for the new Medicaid regulation on MedSync and compliance fills?
The board cannot provide any guidance on Mo Health Net's regulations. You would need to direct any inquiry like this to Mo Health Net's pharmacy program department.
And that's another one, if whoever asked this would like, we have an email address that we can give you that you can email them directly. Let's see, is the supervising physician information still required on controlled substance prescriptions by mid-level practitioners, even though it is no longer required on the labels?
So this depends on the type of mid-level provider. So physician assistants no longer need the supervising physician information on their prescriptions. Nurse practitioners and assistant physicians still are required to by their respective board rules. And that applies to all prescriptions, not just controls. But you are correct that there is no longer a requirement for the collaborating supervising physician's name to be on the controlled substance prescription label.
Okay, let's see. Any guidance on the new requirement to submit annual sterile compounding numbers?
Due to the FDA memorandum of understanding on compounding not being finalized at this time, the board has extended enforcement of the compound reporting required in Rule 2.425 until January 31st of 2025. At that time, in January 2025, pharmacies will report their 2024 data. And you can see our practice guide supplement for more information on this.
Can we still compound omeprazole suspension?
So the commercially available product, I think it's ComboMep is the name, is a combination of omeprazole and sodium bicarbonate. So if you are compounding it with sodium bicarbonate, then you would need a documented medical reason in order to compound it. And this is true, every single prescription. You can't use like a blanket authorization. It has to be documented on each prescription record.
Okay, so we'll now switch to some of the live questions that have come in from the webinar. Someone's asking about clarified TDAP. I don't see it on the slides. It's not on the slides because it was it's not prohibited. It was pre-approved prior to January, so a pharmacist can order and administer that. It can also be given by protocol or medical prescription order. So there is no, it is one of the allowed.
We have a question about must the order state to be administered by pharmacy? And no, that is no longer required to be on the order.
And they're talking there about administration by medical prescription order is what they're talking about.
We have another question asking about CDC recommendation. Is there an age limit on vaccines? Can we immunize infants? You could immunize below the age of 7 with a CDC recommendation based on a prescription order only.
Yeah, the statute for your own authority to order and administer or to buy protocol would be age 7 is the limit for that. Someone's asking to clarify on the transfers of prescriptions. I assume they're, yeah, controlled substance prescriptions. Can you fax over that? If you read the FDA rule, it says it has to be done electronically, and it has to stay in the original electronic format that you received it in. So my interpretation is no, a fax could not be used. Again, this is DEA rules, not the board, so you would need to ask DEA for final clarification if you need that.
We have a question about pharmacies displaying the name of the pharmacist with RPH or some use of degree attained, PharmD. RPH or PharmD would be fine on your name tag if that's what your question is pertaining to. For technicians, they would need to say technician.
Looks like there's a question about a nurse. If they're also a pharmacy technician, can they provide vaccines under their tech license? Yes, they could.
But they would have to follow all the rule requirements related to that.
Yes.
If they did that. Someone's asking about, is ShoMeVax mandatory for all providers? My understanding is no, it is required by statute for pharmacists. I'm not aware if it's required for anyone else. I believe it's voluntary. Again, I can't speak for all licensees. I mean, all practitioner types, but I don't believe it is at this point. Someone's wanting to know where they can go to get, I assume they're asking about where to get certified for immunization. The programs are offered by different organizations. MPA, I believe, still offers it. Schools might offer it, but the APHA is probably the most common immunization program we see pharmacists getting certified through in order to do that. And it's offered by different organizations. If you're looking for that, I would start with maybe an inquiry at MPA to see if they have one scheduled coming up anytime soon. We have someone asking about well, I don't know if they want to know if the board had any conversation with MoHealthNet over how long the requirements in order for a pharmacist to get enrolled with them and the lengthy process. No, not that I'm aware of. The board has not had that. If you have any concerns about that, you would need to talk to MoHealthNet. Someone's asking, can whose name goes, let me make sure I got this right. If you have different pharmacists, one ordering it and one doing the immunizations, I think they're asking whose name goes on the prescription. It would be who's ordering it for the prescription, but your records would have to indicate who is actually the immunizer. It could actually be a qualified technician or a intern, but who's ever ordering it, their name needs to go on the prescription record. Let's see.
Will immunizing technicians be required to show their immunization training, their CPR certification, or any type of certification status during an inspection? And they're also asking where should they keep these documents if they float around a lot? These, so the answer to that question is these documents will be requested on an inspection. It would be up to the pharmacy to decide where to keep these documents for floaters. Inspectors will ask to see them at any location they have immunized at.
Okay, got another question about when does the board anticipate statewide standing order for test to treat? So the new statute requires a standing order to be issued by the Department of Health. And at this time, we haven't heard any information on if or when they would issue one.
We have a question asking if pharmacy manager is an appropriate title on a PIC's name tag, or does it have to say pharmacist? Is PharmD or RPH an acceptable substitution for pharmacist? And the answer to that is pharmacy manager would not be sufficient. The name tag would have to have either pharmacist, PharmD, or RPH to be compliant.
We have someone asking about job shadowing. Can a high school student come job shadowed at a pharmacy? The answer is yes. However, if they're not licensed as a technician, all they can do is watch. They cannot actually perform any kind of practice of pharmacy activities.
Okay, a question about storing records off-site. Does the pharmacy have to let the board know if it is storing records off-site, even if those records are older than what the board requires them to keep? So an example given of more than 5-year-old prescription hard copies. And yes, the rule would apply to any confidential pharmacy records. You'd have to notify the board that you're storing those off-site.
We have another question asking, what can a pharmacy do if an inspector shows up for an inspection, but the PIC is not there? It's a float pharmacist who is staffing the pharmacy. They're asking if they can ask the inspector to come back on another day, and what would happen if they're not able to get the inspector the documents or information they are needing for the inspection. The answer to that is they can ask the inspector to come back a different day, but the inspector will decline that request. As far as the requested documents and information, if it's unable to be provided by the end of the inspection, the inspector may make an observation on the pharmacy inspection report.
Let's see, we have someone asking, clarify, when does a cashier need to be licensed as a technician? So the board issued guidance last year. It's in the practice guide. If the cashier is handling individual filled prescriptions before they're bagged or sacked, they would need to be a technician. That is what would trigger them. If all they're doing is selling a bag that's sealed to the patient, they would not need to be a cashier, assuming that's all they're doing in the pharmacy. They can't go back and do other things that would be, but that's the indicator. We're just about out of time. If we didn't get to your question, or if you have other questions, just some resources on your screen there. The practice guide and its supplement. We do expect to have a full revision of the practice guide by the end of the year. Just a tip, we do have a table of contents at the beginning that has links to each section, but if you're not finding what you need, do a Control F and find, and you search for whatever word you're looking for, and you might be able to find it easier that way if you can't find it in the table of contents. You can always email your inspector with questions. You can email the board office also at missouribop@pr.mo.gov. And then on the board's website, there's mechanisms to submit questions to the inspectors or to the board office, depending on what it's related to. And as Elaine mentioned earlier, for controlled substance questions, BNED has their, this is the email address you can send them to, or the DEA, this is what I would recommend you send your questions to at this email for them. So as I mentioned earlier, we do record the webinars. You will find them on our website in approximately 15 days. And we've had 4 so far this year. You'll find all of them on there also. Next webinar, I believe, will be with the executive director of the Missouri PDMP, but I do not have a date for that webinar. Watch for your e-alerts, and we'll announce that. If you're interested in continuing education, to earn that, do not close your browser. I will say I'm going to end the webinar. A screen will pop up asking you telling you that. You hit close. Again, do not close your browser, and then a survey will open. Answer the questions and click submit. If you do not get the questions electronically like that method, you can always email us at compliance@pr.mo.gov. We'll email you the questions, but you must have your answers back within 24 hours to get credit. We will email out certificates in approximately 30 days. And remember to save them because we do not submit to the CPE monitor. I want to thank Elaine and Katie for being here today with me. And I want to thank you all for joining us on the webinar today. I am now going to close the webinar.